This lecture will summarize Unit 1 in the ATI PN Mental Health Nursing textbook. This will go through chapters 1 through 6, and we'll go through the key points of each chapter. Chapter 1, Basic Mental Health Nursing Concepts. The provision of care to clients in mental health settings is based on the standards of care set by the American Nurses Association, the American Psychiatric Nurses Association, and the International Society of Psychiatric Mental Health Nurses. We use the same nursing process with the same holistic approach to care for all clients. And we're going to continue to use various methods of data collection, including observation, interviewing, physical examination, and collaboration. Data collection. We need to perform physical data collection as indicated for that patient condition or per policy. It's important to include questions relating to difficulty sleeping, incontinence, any falls or other injuries, depression, dizziness, and any loss of energy. Be sure to obtain a detailed medication history, and each encounter with the client would involve ongoing data collection. So you should use every single encounter to continue to get more information about that patient to help you care for them and better their treatment plan. Regarding their psychosocial history, we need to determine their use of any substances and any history of substance abuse disorder. We also need to determine their stress level and any coping abilities that they have, their usual coping strategies, and any support systems in place. As always, we need to identify the patient's cultural healthcare beliefs, practices, and values. We need to be aware of this to alleviate any stereotyping and stigmatizing. We need to determine the patient's support systems and assist them to identify any support persons or resources. Remember that spiritual and religious beliefs will affect the way that patients find meaning, hope, purpose, and a sense of peace within their life. It's important as nurses to support these beliefs, or if they don't exist, to support that as well. A mental status examination, or MSE, would consist of examining the level of consciousness. This would include any observed behaviors, should be documented as well. Is the client alert and responsive, able to fully respond by opening their eyes and responding with a normal tone of voice and speech? Are they lethargic? They're able to open their eyes and respond, but are drowsy and can fall asleep readily. Stuporous would require vigorous or painful stimuli to elicit a brief response, and comatose would be an unconscious patient that would not respond to any painful stimuli. When looking at the physical appearance, this examination would include data collection of personal hygiene, grooming, nutritional status, clothing choice, and if the client looks older than their stated age. When looking at behavior, look at voluntary and involuntary body movements, as well as eye contact. Remember that the mood will provide information about an emotion the client is feeling, but their affect is an objective expression of their mood. For example, a flat affect or a lack of facial expression. When looking at a patient's cognitive and intellectual abilities, we need to check their memory, both recent and remote. Immediate. To check the immediate memory, ask the patient to repeat a series of numbers or a list of objects. To check their recent memory, ask them to recall some recent events, such as visitors from the previous day. For a remote memory, ask them to state a fact from their past that is verifiable, such as their birth date or their mother's maiden name. Ask the patient what they know about their current illness or hospitalization, and determine their judgment based on their answers to hypothetical questions. For example, how would they answer the question, what would you do if a fire was in your room? The patient should provide a logical response. Observe the patient's speech and responses, as they should be meaningful, articulate, and appropriate. We do have some standardized screening tools that we can use to evaluate and monitor our patients. A mini mental state examination, or an MMSE, is an examination used objectively to collect data about a patient's cognitive status. It evaluates their orientation to time and place, their attention span, their registration and recalling of objects, and their language. It's important to have considerations across the lifespan, as different age groups will require a different tailored technique. The patient should always be the source of the information. However, with children and adolescents, caregivers can also provide valuable information. Children and adolescents will experience some of the same mental health problems as adults. Mental health and developmental disorders are not always easily diagnosed, and this can potentially result in delayed or inadequate treatment interventions. Check for the mood, anxiety, developmental, behavioral, and any eating disorders. Of course, always check for the risk of self-injury or suicide. When looking at children and adolescents, we can use the HEAD standardized collection tool. This looks at the home environment, education and employment, activities, drug and substance abuse, sexuality, suicide and depression, and safety. With our older adult population, we need to include an evaluation of their functional ability, their economic and social status, any environmental factors that could affect their well-being and lifestyle, and use standardized data collection tools that are appropriate for that older adult population, including a geriatric depression scale, a Michigan alcoholism screening test, the geriatric version, or an MMSE. When conducting interviews of patients, always use a private, quiet space, make an introduction, and determine their preference of name. Sit or stand at their level to conduct the interview. The Diagnostic and Statistical Manual of Mental Disorders, 5th edition, has been published by the American Psychiatric Association, and this is what is used by mental health professionals to diagnose mental health disorders in patients, following, of course, standard criteria. A serious mental illness would include disorders classified as severe and persistent. These patients often have difficulty with their activities of daily living, and these illnesses are lifelong disorders that can have remissions and exacerbations. Roles and life changes are very important when it comes to our mental health and how it affects our mental health. Role transitions include loss of employment, divorce, retirement, grandparenthood, widowhood, death of a guardian, and becoming a caregiver or recipient of care. Some role changes can be predicted, however, others can be unexpected. It's important to identify the patient's ability to adapt and cope. That would include their health status and functional ability, their living arrangements, and their employability, any personal factor like their attitude, the patient and any family observations, the level of information, and any medication use. We need to evaluate whether or not the patient has successfully adapted. That would include their ability to state positive coping behaviors, their ability to identify maladaptive coping behaviors, their ability to participate in community resources and list stress reduction techniques, and their ability to maintain housing and employment. There are some therapeutic strategies in the mental health setting. These include counseling, myelotherapy, promotion of self-care activities, psychobiological interventions, cognitive and behavioral therapies, health teaching, health promotion and maintenance, and case management. As we continue to explore this textbook, we'll learn more about each of those different strategies. Chapter 2, Legal and Ethical Issues. A nurse who works in a mental health setting is responsible for practicing ethically, competently, safely, and in a manner consistent with all local, state, and federal laws. It's very important to have an understanding and to be able to protect the client's rights. Of course, our patients in a mental health setting are guaranteed the same civil rights as any other citizen. These patients also have various specific rights, including their right to informed consent and the right to refuse treatment. They have a right to confidentiality, a right to a written plan of care or treatment that includes a discharge follow-up, communication with people outside of the mental health facility. They have a right to provision of adequate interpretive services if needed. They have a right to have care that is provided with respect, dignity, and without any discrimination. They have a right to freedom from harm. They have a right to a psychiatric advance directive that would include their treatment preferences. And they have a right to a provision of care with the least restrictive interventions necessary to meet their needs, without allowing them to be a threat to themselves or others. Some legal issues regarding healthcare are decided in court using a specialized civil category called a tort. A tort is a wrongful act or injury committed by an entity or person against another person or another person's property. Torts can be used to decide liability issues, and we'll get into them a bit more later on. State laws can vary greatly, and it is your responsibility to know the laws of the state you're practicing in. The nurse can experience situations where there might be a conflict between two or more courses of action. This is known as an ethical dilemma. In these situations, the nurse should respond using bioethical principles. The nurse must use ethical principles to decide any ethical issues. These would include the following. Beneficence. This is the quality of doing good. Autonomy. This is the client's right to make their own decisions. Justice. This means fair and equal treatment for all. Fidelity. This is loyalty and faithfulness to the patient and to your duty as a nurse. And veracity. This is honesty whenever dealing with a patient. Confidentiality. The patient's right to privacy is protected by the Health Insurance Portability and Accountability Act, or the HIPAA law. Specific mental health issues where healthcare professionals can break confidentiality would include the duty to warn and protect third parties and the reporting of child and vulnerable adult abuse. There are different types of admissions to a mental health facility. An informal admission, this is a least restrictive form of treatment. In this situation, the patient would not pose a substantial threat to themselves or others, and they would be free to leave the hospital at any time, even against medical advice. Then there's a voluntary admission. In this situation, the patient's admission to a mental health facility is voluntary in order to obtain treatment. They're considered competent, and they do have the right to refuse medication and treatment. Before the release, the patient does need to be evaluated, and if necessary, then the doctor or care provider can initiate an involuntary admission. There's a temporary emergency admission. This is when the patient is admitted for emergent mental health care due to the inability to make decisions regarding their care. The medical health care provider can initiate the admission, and the patient then needs to be evaluated by a mental health care provider. There needs to be a court hearing within 72 hours and then another hearing in 7 to 21 hours, depending on the state requirements. And then there's an involuntary admission. This is when the patient enters a mental health facility against their will for an indefinite period of time. This admission is based on the patient's need for psychiatric treatment, their risk of harm to self or others, or their inability to provide self-care. There are criteria that need to be met for an involuntary admission. They include the presence of a mental illness. The patient must pose a danger to themselves or others. The patient must demonstrate severe disability or inability to meet their basic necessities. This would include food, clothing, and shelter. And the patient would need to require treatment but be unable to seek it voluntarily due to the impact of their mental illness. The patient can request a legal review of their admission at any time. For an involuntary admission, a psychiatric and legal review of the admission is required. Patients admitted under involuntary commitment are still considered competent and do have the right to refuse treatment, including medication. Patients have rights regarding seclusion and restraint. The use of seclusion rooms and/or restraints can be warranted and authorized for patients in some cases. Restraints can be either physical or chemical. A patient can voluntarily request a temporary timeout in cases where the environment is just disturbing or too stimulating for them. A timeout is different from a prescribed seclusion because a timeout is being requested by the patient. The provider should provide seclusion and/or restraint for the shortest duration necessary and only if less restrictive measures have not been sufficient. Less restrictive measures would include verbal interventions, diversion or redirection, providing a calm, quiet environment, or offering a PRN medication. Though technically this is a chemical restraint, medications are considered less restrictive than a mechanical restraint. The nurse should never use seclusion or restraint for the following: convenience, punishment of the client, for a client who is extremely physically or mentally unstable, or for a patient who cannot tolerate the decreased stimulation of a seclusion room. Whenever using seclusion or restraints, the provider must provide this order in writing. Time limits for seclusion or restraints are based upon the age of the client. For a patient 18 years or older, the time limit is 4 hours. For a patient 9 to 17 years, the time limit is 2 hours. And for a patient 8 years or younger, the time limit is 1 hour. The physician would need to rewrite this prescription every 24 hours or per facility policy. The facility protocol should identify the nursing responsibilities, including how often that patient should be monitored, offered food and fluid, toileted, have vital signs taken, and be monitored for pain. It's important to complete documentation every 15 to 30 minutes. That would include a description of any precipitating events and behaviors of the patient prior to the seclusion or restraint. Any alternative actions that were taken to avoid that seclusion or restraint, the time that you began seclusion or restraint, the current patient's behavior, any food or fluids taken, where their needs provided for, and of course their vital signs, any medication administration that was done, and of course the time released from the restraints. The nurse can use the seclusion or restraints without first obtaining a provider's written order if it's an emergency situation. Restraint or seclusion must be discontinued when the patient is exhibiting behavior that is safer and quieter. Once restraints or seclusion are discontinued, the nurse must then obtain a new prescription before initiating the restraints again. An intentional tort is a willful action that damages a patient's property or violates their rights. False imprisonment would be considered an intentional tort, as well as assault and battery. Unintentional torts are actions or inactions that cause unintended harm as a result of failing to meet one's duty of care in either a personal or professional situation. This would include negligence and malpractice. It is vital to clearly and objectively document information related to any violent or unusual episodes. When these occur, you must document the following: their behavior in a clear and objective manner, the staff response to any disruptive, violent, or potentially harmful behavior. Be sure to include a timeline and the time the nurse notified the provider and any prescriptions then received. Chapter 3, Effective Communication. Communication is a complex process, and it's a skill that the nurse needs to develop. We use communication to provide care and establish relationships, to demonstrate caring, obtain information, and assist with changing our patient behaviors. We have some basic levels of communication. We have intrapersonal communication. This is your self-talk. In nursing, intrapersonal communication will allow the nurse to perform a self-assessment of their values or their beliefs prior to caring for a patient whose diagnosis might trigger an emotional response. There is interpersonal communication. This is communication that occurs one-on-one with another person. In nursing, interpersonal communication is used when the nurse obtains a psychosocial history from a patient or when listening to a patient discuss their feelings. There's small group communication. This would occur between 2 or more people in a small group. In nursing, this can allow the nurse to discuss a change in the patient's behavior with a healthcare team or discuss concerns with clients during a group therapy session. There's public communication. This would occur within large groups of people. In nursing, this would typically occur with educational endeavors where the nurse is collaborating with the RN to educate a large group of individuals. And there's electronic communication. This is using technology. It's also timely between the patient and the healthcare provider. This can help the patient stay engaged with their care and also develop ongoing relationship with their healthcare provider. When looking at verbal communication, we need to consider a patient's vocabulary. The use of medical jargon we know can decrease a patient's understanding. We need to look at denotative and connotative meaning. When communicating, it's important that participants share their meanings. Words that have multiple meanings can cause a miscommunication. Clarity and brevity. We want the shortest, simplest communication. That is typically the most effective. Timing and relevance. It's important to communicate with a patient who is not in pain or is not distracted. Whenever patients are distracted or in pain, it'll be difficult for them to understand the message you're trying to give them. Pacing. The rate of speech can communicate a meaning to a receiver. So speaking rapidly can communicate the impression that the nurse is in a rush and doesn't have time for the patient. And intonation. The tone of voice can communicate a variety of feelings, and the nurse can communicate many feelings through their tone of voice. Nonverbal communication is also so important, and it's very important the nurses be aware of how they're communicating nonverbally. Nonverbal communication can have more impact on the message compared to the verbal words. Attention to the following behaviors is very important, as it's compared to the verbal message that's also being conveyed. Look at their appearance, posture, gait, facial expression, eye contact, gestures, sounds, territoriality, personal space, and silence. Therapeutic communication is essential when caring for a patient with a mental health disorder. This is because of the emotional and physical effects of the disorder on the patient. The nurse must use their interactive, purposeful communication skills to elicit and attend to a patient's thoughts, feelings, concerns, and needs, to express empathy and genuine concern, to obtain information and give feedback about a patient's condition, to intervene and promote functional behavior and effective interpersonal relationships, and to monitor a patient's progress towards goals and outcomes. Therapeutic communication is client-centered. It is not social or reciprocal. This is purposeful, planned, and goal-directed communication. There are some essential components to therapeutic communication. Time. Plan for and allow adequate time to communicate. Clients who have certain mental health disorders, such as major depressive disorder or schizophrenia, can require a longer period of time to respond to questions. Be sure to attend to behaviors and display active listening. Eye contact will typically convey interest and respect, but this can vary according to situation and culture. Be aware of your body language, voice quality, and verbal tracking that would provide feedback by restating or summarizing a patient's statements. It's essential to have a caring attitude, to show concern and facilitate an emotional connection with the patient and their family. Be honest, open, direct, truthful, and sincere. Allow the patient to trust you by demonstrating reliability without doubt or question. Display empathy by conveying an objective awareness and understanding feelings, emotions, and behaviors of others. Do this by trying to envision what it must be like to be in their position. And always have a non-judgmental attitude. This is a display of acceptance that encourages open, honest communication. We're going to continue to use our nursing process. We're going to collect data about verbal and nonverbal communication needs. We need to recognize any congruency or non-congruency between any verbal and nonverbal messages. Consider the patient's developmental level and how communication should be adapted to that. For children, use simple, straightforward language and be aware of their level of development. For adolescents, determine how they perceive their mental health diagnosis. For older adult clients, minimize any distractions and face them directly when speaking. Allow plenty of time for them to respond. When planning, identify mutually agreed upon patient outcomes and set priorities according to the patient's needs. When implementing these interventions, establish a trusting nurse-patient relationship. Be sure to assist with providing empathetic responses and explanations to the patient by using observations, as well as providing hope, humor, and information. We are going to review some effective communication skills and techniques, as well as some barriers to effective communication. Effective therapeutic communication techniques include silence, active listening, questions, open-ended questions, and close-ended questions, Be careful about using repeated closed-ended questions, which can sometimes block further communication. Use projective questions and presupposition questions. There are clarifying techniques, such as restating, reflecting, paraphrasing, and exploring. You can offer general leads, such as broad opening statements. It's important to show acceptance and recognition. Focusing, giving information, presenting reality, summarizing, offering self, and when appropriate, touch. Some barriers to effective communication include asking irrelevant personal questions, offering personal opinions, giving advice, giving false reassurance, minimizing feelings, changing the topic, asking why questions, offering value judgments, excessive questioning, and giving approval or disapproval. Chapter 4, Stress and Defense Mechanisms. Individuals can use defense mechanisms as a way to manage conflict in response to anxiety. Defense mechanisms are reversible, and the patient can use them in either an adaptive or a maladaptive manner. Adaptive use of defense mechanisms would help people achieve their goals in an acceptable way and reduce their anxiety. Defense mechanisms can become maladaptive when they interfere with functioning, relationships, and orientation to reality, or when they're used in excess. Altruism and sublimation are defense mechanisms that are always healthy. Other defense mechanisms can be used in a healthy manner. However, they can become maladaptive when used inappropriately or repetitively. Consider the frequency, intensity, and duration of use of the client's defense mechanisms to determine whether they are adaptive or maladaptive. Altruism is dealing with anxiety by reaching out to others. Sublimation is dealing with unacceptable feelings or impulses by unconsciously substituting an acceptable form of expression. Suppression is voluntarily denying unpleasant thoughts and feelings. Repression is unconsciously putting unacceptable ideas, thoughts, and emotions out of your awareness. Regression is the sudden use of childlike or primitive behaviors that don't correlate with a person's current developmental level. Displacement is shifting feelings relating to an object, person, or situation to another less threatening object, person, or situation. Reaction formation is overcompensating or demonstrating the opposite behavior of what is felt. Undoing is performing an act to make up for prior behavior. This is commonly seen in children. Rationalization is creating reasonable and acceptable explanations for unacceptable behavior. Disassociation is creating a temporary compartmentalization or lack of connection between a person's identity, memory, or how they perceive their environment. Denial is pretending the truth is not reality to manage unpleasant, anxiety-causing thoughts or feelings. Compensation is emphasizing strengths to make up for weaknesses. Identification is the conscious or unconscious assumption of characteristics of another individual or group. Intellectualization is the separation of emotions and logical facts when analyzing or coping with a situation or event. Conversion is responding to stress through unconscious developments of physical manifestations not caused by a physical illness. Splitting is demonstrating an inability to reconcile negative and positive attitudes of self or others. Projection is attributing one's unacceptable thoughts and feelings onto another who doesn't have them. Anxiety is viewed on a continuum, with increasing levels of anxiety that can lead to decreasing ability to function. A normal state of anxiety is a healthy life force that is necessary for survival, and normal anxiety will help motivate people to take action. Acute or immediate state anxiety is a level that is precipitated by an imminent loss or change that would threaten one's sense of security. A chronic or sustained trait of anxiety is a level that usually develops over time, typically starting in childhood. The adult who experiences chronic anxiety may display that anxiety in physical manifestations, such as fatigue or frequent headaches. When collecting data with our anxiety population patients, we want to consider their level of anxiety. A mild level of anxiety would occur in the normal experience of everyday living. This increases one's ability to perceive reality, and there's always an identifiable cause for that anxiety. These patients can demonstrate tapping of the foot or finger, chewing on their lip, or other restless behavior to help relieve that tension. Then there's moderate anxiety. This occurs when mild anxiety escalates. The ability to think clearly is now hampered, but learning and problem solving can still occur. Other characteristics of moderate anxiety include concentration difficulties, tiredness, pacing, change in voice pitch, voice tremors, shakiness, increased heart rate, and respiratory rate. The patient who has this type of anxiety would typically benefit from the direction of others. Then there's a severe level of anxiety. Learning and problem solving do not occur. Functioning is effective, but behaviors are now automatic. The patient who has severe anxiety is usually not able to take any direction from others. And then the highest level is panic level anxiety. Panic level anxiety is characterized by markedly disturbed behavior. The patient is not able to process what is occurring in the environment and can lose touch with reality. They would experience severe hyperactivity, fight, flight, or immobility. Other characteristics include dysfunction in speech, dilated pupils, severe shakiness, severe withdrawal, inability to sleep, delusions, and hallucinations. Nursing interventions need to be implemented according to the patient's level of anxiety that they are experiencing. For mild to moderate anxiety, we need to use active listening to demonstrate willingness to help and use specific communication techniques, such as open-ended questions, giving broad openings, exploring, and seeking clarification. We need to provide a calm presence for these patients and recognize their distress. We need to evaluate any past coping mechanisms that they've had and explore some alternatives to their current problem situation. We also need to encourage participation in activities like exercise that can temporarily relieve these feelings of inner tension. For severe to panic anxiety, as nurses, we need to provide an environment for them that will meet their physical and safety needs. Stay with them and stay calm. Provide an environment that is quiet with minimal stimulation. Use medications, seclusions, or restraint, but only after you've tried less restrictive interventions. Encourage gross motor activities like walking or another form of exercise. Set limits by being firm, short, and simple with your statements. Repetition can be necessary. Speak slowly and in a low-pitched voice. Direct the patient to acknowledge reality and focus on what's present in their environment. Chapter 5, Creating and Maintaining a Therapeutic and Safe Environment. Therapeutic encounters can occur in any setting if a nurse is sensitive to a patient's needs and uses effective communication skills. This therapeutic nurse-patient relationship is absolutely foundational to nursing care in a mental health setting. A therapeutic nurse-patient relationship would have the following characteristics. It is purposeful and goal-directed. It is well-defined with very clear boundaries. It's structured to meet the patient's needs. And it's characterized by an interpersonal process that is safe, confidential, reliable, and consistent. Myelotherapy would create an environment that's supportive, therapeutic, and safe. It can also be referred to as a therapeutic community or a therapeutic environment. The goal is that while the patient is in the therapeutic environment, they will learn the tools necessary to cope adaptively, interact more effectively and appropriately, and strengthen their relationship skills. The hope is that the patient will use these tools in other aspects of their life. The nurse, as the manager of care, is responsible for structuring or implementing aspects of the therapeutic milieu within the mental health facility. The role of the nurse includes the role to identify and explore a patient's needs and problems, the role to help develop a patient's strength and new coping skills. We need to assist the patient to develop a sense of autonomy and self-reliance. And we also need to practice empathy by remaining non-judgmental and attempting to understand the patient's actions and feelings. This differs from sympathy, which is not therapeutic, in which the nurse would allow themselves to feel the way the patient does. Some characteristics of the therapeutic milieu include the physical setting. It should be clean and orderly. It should include comfortable furniture placed in a way so that it promotes interaction, solitary spaces for reading and thinking alone, and comfortable places that are conducive to meals, as well as quiet areas for sleeping. There are some healthcare team member responsibilities, including promoting independence for all patients, including their self-care, treating patients as individuals, including fair treatment for all, working cooperatively as a team to provide care, modeling good social behavior for patients, promoting feelings of self-worth and hope for the future. These patients should feel cared for and accepted by the health team. Some benefits of a therapeutic relationship can have very positive outcomes for the patient. These relationships do take time to establish, but even time-limited therapeutic encounters can be positive on the patient. Supervision by peers or the clinical team will enhance a nurse's ability to examine their own thoughts and feelings, maintain boundaries, and continue to learn from their nurse-patient relationships. Boundaries do need to be established in order to maintain a safe and professional nurse-patient relationship. A social relationship's primary purpose is for socialization or friendship, with the focus on the mutual needs of the individual. Instead, a therapeutic relationship has a primary purpose to identify a client's problems or needs, then focus on assisting that client in meeting or resolving those issues. So a therapeutic relationship is completely one-sided, whereas a social relationship, such as a friendship, is two-sided. You have to meet in the middle. You both have to put in the work to make it work. And you're both equally involved in each other's well-being and goals. Whereas a therapeutic relationship, it is completely one-sided. We are helping that patient identify their problems or needs, and then we are assisting them in reaching those goals. We need to work to maintain a consistent level of involvement with them, but also reflect on boundary issues frequently and maintain awareness of how these behaviors can be perceived by others, such as family members and other healthcare team members. Transference occurs when a patient views a member of the healthcare team as having characteristics of another person who has been significant to them in their life. Some behaviors that the patient may exhibit would be expecting exclusive services from this nurse, such as extra session time. The patient may demonstrate jealousy of the nurse's time or attention, and the patient may compare the nurse to a former authority figure. In this situation, the nurse needs to be aware that transference by a client is more likely to occur with a person in authority. Countertransference would occur when a healthcare team member displaces characteristics of people from their past onto a client. In this situation, the nurse would overly identify with the client. The nurse would feel themselves competing with the client and would even argue with the client. In this situation, a nurse needs to be aware that patients who produce very strong personal feelings like that can become objects of countertransference. This can directly interfere with the nurse-patient relationship. Physical safety is always an important factor to consider. The nurses stationed in other areas should be placed to allow for easy observation of clients by staff and access to staff by the clients. We need to set up the following provisions to prevent client self-harm or harm to others. So there should be no access to any sharp or harmful objects. There needs to be restriction of client access to any restricted or locked areas. We need to monitor any visitors. We need to restrict alcohol, illegal substances, as well as sexual activity among the patients. We need to deter any elopement from the facility, and we need to provide rapid de-escalation of any disruptive and potentially violent behaviors. This will occur through planned interventions by trained staff. Seclusion rooms and restraints need to be set up for safety and only used after all less restrictive measures have been exhausted. Considerations of room assignment on a 24-hour care unit needs to include the personalities of each roommate, the likelihood of any nighttime disruptions for a roommate if one client has a difficult time sleeping, any mental health and medical diagnoses, such as how two clients with severe paranoia might interact with each other. There are different activities that we can do within a therapeutic milieu. These therapy activities are always structured and include time for community meetings. These will enhance the emotional climate of the therapeutic milieu by promoting interaction and communication, decision-making, a feeling of self-worth, discussions of common unit objectives, and discussion of issues of concern to all members of the unit. These meetings can be structured so that they are patient-led, with decisions then made by the group as a whole. There are different types of therapies that we can do within our therapeutic milieu, such as individual therapy, group therapy, psychoeducational groups, recreational activities, and unstructured flexible time. There are different phases and tasks of therapeutic working relationships. We begin with orientation. The nurse introduces themselves to the patient and they set the purpose of the meeting. You set the contract, the meeting time, the place, the frequency, the duration, and of course, the date of termination. We build trust and set goals with the patient. The patient needs to participate in setting those goals. Then you move on to the working phase of the relationship. In this phase, the nurse is performing ongoing data collection to plan and evaluate any therapeutic measures. We're encouraging the patient to problem solve. We are exploring and dealing with resistance and any other defense mechanisms. We're reevaluating the patient's problems and goals and always assisting with revision of plan as necessary. The patient needs to be reconsidering their usual coping behaviors. They need to experience intense feelings and learn to cope with their anxiety reactions, and they need to try alternative solutions. In the termination phase of the therapeutic relationship, the nurse needs to provide an opportunity for this patient to discuss their thoughts and feelings about this termination and loss. We need to summarize the patient's goals and achievements, and we need to maintain the limits of final termination. The patient needs to examine their previous separation and loss experiences. They need to discuss plans to continue their new behaviors and make plans for their future. They also need to accept that termination as final. Chapter 6, Diverse Practice Settings. Mental health nursing can occur in acute care and community settings, as well as in forensic nurse settings. In all settings, nurses are always advocates for patients with mental illness. Referral of patients and their families to organizations and agencies that provide additional resources can also be a significant support to individuals. We have different settings for our mental health care. The acute care setting. This setting will provide intensive treatment and supervision in locked units. These are for patients who are in emotional crisis and present a danger to themselves or others. The care in these facilities will help stabilize mental illness manifestations and promote a patient's rapid return to community. Case management programs will assist with patient transition to a community setting after discharge from that acute care facility. Then we have the community setting. Primary care is provided in community-based settings, which include clinics, schools, and daycare centers, partial hospitalization programs, substance treatment facilities, forensic settings, psychosocial rehabilitation programs, telephone crisis counseling centers, and home health care. They also assist with teaching, support, and making referrals in order to promote positive social activities in the community. Forensic nursing is a combination of biophysical education and forensic science. This is the utilization of nursing science to public or legal proceedings. The registered nurse will use scientific investigation, collection of evidence, analysis, prevention, and treatment of trauma and/or death perpetrators and victims of violence, abuse, and traumatic incidents. Let's look at some history of mental health care in the United States. Most patients with severe mental illness were solely treated in acute care facilities before the middle of the 20th century. Congress passed a series of acts in 1946, 1955, and 1963 in response to the appalling condition of facilities for the mentally ill. This started a trend to deinstitutionalize mental health care. The concept of case management was then introduced around 1970 to meet some individual needs of patients in a mental health setting. In 1999, mental illness was defined as a disability in the Americans with Disabilities Act, stating those individuals with mental illnesses had a right to live in the community. Managed behavioral health care organizations were later developed to coordinate care and limit stays in acute care facilities for patients needing mental health care. Then this started a trend to develop a continuum of acute care facilities and community mental health-based facilities to provide for all levels of behavioral health care needs. Factors that will affect our future of mental health care include the following: an increase in our aging population, an increase in the cultural diversity within the United States, and the expansion of technology, which can provide new settings for patient care, as well as new ways to treat mental illness more effectively. Providing patient care in the acute mental health care setting. There is criteria that justifies admission to an acute care facility. This would include a clear risk of the patient's danger to themselves or others, an inability to meet their own basic needs, failure of the patient to meet expected outcomes of a community-based treatment plan, a dangerous decline in the mental health status of a patient undergoing long-term treatment, and a patient having a medical need in addition to a mental illness. Goals of acute mental health treatment would include prevention of the patient harming themselves or others, stabilizing a mental health crisis, and return of the patient who is severely ill to some type of community care. Within all of these settings, we're going to work with our interprofessional team members. These are team members in acute care, including nurses, mental health workers, psychologists, psychiatrists, and other general health providers, social workers, counselors, occupational and other specialty therapists, and pharmacists. Plans for discharge from an acute mental health setting to home or a community facility would always begin from the time of admission and then continue with the implementation of the initial treatment plan. Our nursing roles include the overall management of the acute unit, including patient activities and the therapeutic milieu, ensuring safe administration and monitoring of patient medications, implementation of individualized patient treatment plans, including assisting with patient teaching, documentation of the nursing process for each patient, and managing any crises as they arrive. In the community health setting, the nurse plays a vital role in linking acute care facilities with community care facilities. There are intensive outpatient programs that can promote reintegration for patients. We have 3 levels of prevention that we use when implementing community care interventions. There is primary prevention. This will promote health and emphasize efforts on preventing any mental health problems from ever occurring. An example of this would be a community program on stress reduction techniques. So you're trying to head off the problem before it even gets there. Secondary prevention. This is now going to focus on early detection of mental illness. A good example of this would be screening the older adult in the community for depression. Then you have tertiary prevention. This is going to focus on rehabilitation and prevention of further problems in patients who have a previous diagnosis. Mental illness is present in this tertiary prevention, and the goal is to prevent any further deterioration or complications. There are community-based mental health programs. These are a continuum of mental health agencies with varying treatment intensity levels to allow our patients to remain safe in a least restrictive environment possible. There are partial hospitalization programs. These programs provide intense, short-term treatment for patients who are well enough to go home every night and who have a responsible person at home to provide a safe and supportive environment. There is assertive community treatment, or ACT. This includes non-traditional case management. ACT can help reduce recurrences of hospitalizations and provide crisis intervention, assistance with independent living, and information regarding resources for necessary support services. ACT teams work with clients in their homes and in agencies, hospitals, and clinics. We also have community mental health centers. These facilities will provide a variety of services for a wide range of community clients, including educational groups, medication dispensing programs, and individual and family counseling programs. There are psychosocial rehabilitation programs, which would provide a structured range of programs for patients in a mental health setting. This can include residential services and day programs for older adults. And then, of course, there is home care. Home care is implemented most often for children, older adults, and patients with medical conditions. With psychiatric home care, there are 4 criteria that needs to be met. The patient must be homebound, have a psychiatric diagnosis, need the skills of a mental health nurse, and a plan of care developed by a healthcare provider.